All right, let's jump right into this comprehensive explainer on meningitis. If you're managing complex neurological infections, you already know that the classic textbook presentation of bacterial meningitis is really only half the story. So today we're doing an exhaustive point-by-point breakdown of the atypical variations, specifically recurrent, chronic, and chemical meningitis. And because precision is literally everything in these cases, we're also locking down the exact organism-by-organism pharmacological protocols. We want to make sure you never miss a critical diagnostic or treatment threshold. To make sure we don't skip a single detail, here's our roadmap. We'll start with recurrent and chronic meningitis, define chemical meningitis, and cover its evaluation and treatment. Then we'll hit gram-positive antibiotics, move on to gram-negative and fungal treatments, and wrap up with strict duration guidelines.
Okay, Section 1. Recurrent and chronic meningitis. We're starting our deep dive here because these presentations demand a much wider differential right out of the gate.
Let's start with recurrent meningitis. The absolutely crucial point here is that if a patient just keeps getting meningitis, you have to immediately evaluate for an abnormal physical communication with the intraspinal or intracranial compartment. You are actively looking for structural breaches. Going point by point through the top etiologies, you want to look for a dermal sinus, which, by the way, can be either spinal or cranial. You're also checking for a cerebral spinal fluid fistula or a neuroenteric cyst. These anatomical defects basically leave the central nervous system wide open to repeated bacterial invasions. You literally cannot cure the recurrent infections without fixing that underlying structural leak. Now, shifting gears to chronic cases. When symptoms linger and become chronic, we have to look way beyond your typical acute bacteria. Your primary infectious culprits shift to things like tuberculosis, fungal infections, and parasitic invasions, specifically cysticercosis or neurocysticercosis. But equally important is your differential diagnosis. You have to step back and consider non-infectious systemic issues. We're talking sarcoidosis and, crucially, meningeal carcinomatosis, which is where cancer cells have actually infiltrated the meninges. Moving right along to Section 2, defining chemical meningitis. Let's focus in on a very specific and honestly often misunderstood non-infectious culprit. It is absolutely vital to recognize that not all meningeal inflammation requires antibiotics. Chemical meningitis is a really fascinating subset of aseptic meningitis. The inflammation here is entirely non-infectious. Instead of bacteria, the meninges are reacting to an irritant. As we can see laid out here, that irritant is typically drugs, the leakage of tumor contents, or postoperative debris. Mixing this up with bacterial meningitis is a huge trap that can lead to unnecessary, prolonged antibiotic use. When we talk about drug-related causes, we're usually looking at intraventricular delivery systems. Contrast agents can definitely trigger this, but what's really striking is intrathecal methotrexate. It causes chemical meningitis in a reported 3% of patients receiving it. Think about that, 3 out of every 100 patients. If your patient is on IT methotrexate and develops meningeal signs, this chemical reaction needs to be right at the top of your differential. But it's not just drugs. Chemical meningitis can happen spontaneously from leaking tumor or cyst contents. Classically, we see this with epidermoid cysts or craniopharyngiomas. Though much more commonly in a surgical setting, it happens postoperatively, particularly after intracranial operations in the posterior fossa. Now, pay very close attention to the timeline here. The onset is usually 3 to 7 days following surgery, but it can actually be delayed for weeks. And here is the major clinical pitfall. These patients might completely lack classic fever and meningeal signs. You really have to maintain a high index of suspicion. Section 3. Evaluating and treating chemical meningitis. Since those classic signs might be totally missing, and it perfectly mimics a post-op infection, let's break down exactly how we evaluate and treat this variant. Cerebrospinal fluid analysis is everything here. Notice the difference in the lab values. The crucial data points are the white blood cell to red blood cell ratio and the glucose levels. In chemical meningitis, that WBC to RBC ratio usually isn't as high, and the glucose isn't as low compared to an infection. In fact, one major clinical series gave us a fantastic hard data threshold. They found absolutely 0 patients with chemical meningitis who had a CSF white blood cell count greater than 7,500 per microliter combined with a CSF glucose less than 10 milligrams per deciliter. If you hit those extreme numbers, you're dealing with an infection, for sure, not a chemical reaction. Even with those great thresholds, you cannot skip the thorough evaluation steps. As mapped out here, routine cultures are obviously critical. But remembering what we discussed earlier about chronic meningitis, you must specifically request 3 additional cultures: fungal, TB, and viral. Furthermore, always, and I mean always, send the CSF for cytology to look for malignant cells. Remember, carcinomatous meningitis can easily masquerade in these ambiguous chemical profiles, and that is a diagnosis you definitely do not want to miss.
Once you've confidently confirmed it's chemical meningitis, the treatment relies heavily on symptom control rather than blasting the patient with broad-spectrum antibiotics. Let's go point by point. First, for spontaneous cases, you remove the offending tumor when possible. Second, because it's usually self-limited, you manage the inflammation using the lowest effective dose of systemic steroids. Third, you can remove CSF via serial lumbar punctures or a lumbar drain to relieve pressure. And a final pro tip: if your patient has a persistent headache, check for a pseudomeningeal. If it's there, close it.
Section 4, gram-positive pathogen antibiotics. Speaking of avoiding unnecessary antibiotics, when you do actually have a confirmed bacterial infection, you need to be exact. Let's transition into our highly structured organism-by-organism matrix.
Notice how this breakdown focuses heavily on the minimum inhibitory concentration, or MIC. That's essentially how susceptible the bacteria is to the drug, and it explicitly dictates your choice. For strep pneumogeny, if the MIC is less than or equal to 0.06, you can stick with penicillin G or ampicillin, with ceftriaxone as an alternative. But if that MIC jumps to greater than or equal to 0.12, ceftriaxone becomes your primary. If there's cephalosporin resistance, you've got to add vancomycin. Now, for Neisseria meningitidis, the threshold shifts slightly. An MIC of 0.1 is your hard dividing line between penicillin G and escalating to ceftriaxone. For Staph aureus, your immediate decision branch is methicillin susceptibility. It completely alters your baseline protocol. If it's methicillin susceptible, MSSA, you go with oxacillin or nafcillin. You reserve vancomycin only if there's a true penicillin allergy. But if you're dealing with MRSA, vancomycin with or without rifampin is your primary weapon, and linezolid acts as your backup alternative.
Let's move to Haemophilus influenza. Here, beta-lactamase testing dictates our path. If the organism doesn't produce this resistance enzyme, meaning it's beta-lactamase negative, ampicillin works perfectly. But if it is beta-lactamase positive, it'll just destroy the ampicillin. So you get bumped straight up to a 3rd-generation cephalosporin, typically ceftriaxone. If you happen to need alternatives for a positive strain, aztreonam or ciprofloxacin are your go-to options. Ampicillin remains an absolute workhorse for our next 2 pathogens. For group B strep, ampicillin is primary, with vancomycin as the backup. For Listeria monocytogenes, ampicillin is still primary, but note the potential addition of IV gentamicin. If a patient just cannot tolerate that regimen, IV sulfamethoxazole trimethoprim serves as an excellent alternative. Section 5, gram-negative and fungal treatments. Okay, let's flip the script. We're moving away from gram-positives to tackle gram-negative bacilli and fungal invaders, which require a completely different class of pharmacological weapons.
These gram-negative organisms can be remarkably tricky. For general aerobic gram-negative bacilli, you're looking at ceftriaxone, cefotaxime, or moxifloxacin. In special circumstances where an aminoglycoside is required after the newborn period, intraventricular therapy might actually be indicated. Now look at Pseudomonas aeruginosa. It is notorious. You need ceftazidime or cefepime as your first line, with meropenem or ostrinam as backups. Most importantly, if Pseudomonas causes ventriculitis, you must strongly consider direct intrathecal delivery of gentamicin or tobramycin.
And we absolutely cannot forget fungal meningitis. For Candida species, you need to commit this exact dual therapy protocol to memory. You combine liposomal amphotericin B, given IV daily at 3 to 4 milligrams per kilogram, plus flucidosine, given orally 4 times a day at 25 milligrams per kilogram. It is a highly aggressive synergistic approach, but it's completely necessary to penetrate the blood-brain barrier effectively and clear the fungus. Section 6, Treatment Duration Guidelines. We've precisely matched the drugs to the bugs, but how long do we actually deploy them? Let's look at the strict rules governing treatment length. The golden rule for general bacterial meningitis treatment duration is 10 to 14 days total. Of course, this is ultimately dependent on the specific organism and how well your patient responds clinically, but this 10 to 14-day window is your standard, rock-solid baseline. But you cannot forget the exceptions. This is exactly where clinical errors happen. You must extend treatment to a full 21 days for 3 specific categories: Listeria, Group B strep, and certain gram-negative bacilli. Stopping at day 14 for these specific pathogens drastically increases the risk of a devastating relapse. We have covered a massive amount of clinical data in this explainer today, going point by point from anatomical defects to exact MIC thresholds, all beautifully mapped out in these watercolor-themed visuals. But I want to leave you with this final thought to ponder. How does mixing up a chemical reaction with a bacterial infection fundamentally change your patient's outcome? Think about the risks of prolonged unnecessary systemic antibiotics versus the simple removal of toxic CSF. Precise identification is everything. Thanks for exploring this complex topic with me today, and keep utilizing structure to drive your clinical mastery.